All right, can you guys see the correct view, meaning the one that's not my presenter view? It's actually the full screen.
Yeah.
All right, awesome. All right, well, good morning, everyone. I think I know all of you, but my name is Crystal Bong, and I am the Associate Medical Director for Digital Health and the Associate Medical Director for Digital Primary Care. I used to actually be the Associate Medical Director for the Central Region. So, you know, I exist here in the neighborhood clinics. I practice at Ravenna, so have a pretty good grasp of what life is like at the clinic. And I'm super excited today to be bringing you continuous glucose monitoring, remote patient monitoring for real. I think a lot of you guys know that we have been doing some pilots within UWPC. In fact, I think hypertension kicked off about a year ago, a little bit over a year ago. That was our first pilot. And then we did run a CGM pilot at Issaquah, Issaquah, Woodinville, and Ravenna. And that wrapped at the end of October. And then we got busy with the work group, kind of learned from some of the highs and lows of the pilot. And now we have this iteration of the product to share with you guys. This will not be the last iteration. As you know, technology is somewhat of a fickle friend, and we're hoping that we can even get further enhancements and integration to Epic in the future. But this program actually works quite well, and actually, the tools are ready and live for you guys to use in Epic. So let's jump in. So what is remote patient monitoring? I think most of you guys know the answer to this question, but remote patient monitoring, otherwise known as RPM, uses devices to remotely collect and send data for interpretation. I think most of us have already kind of informally been doing this in less validated ways. I think a lot of my patients will send me crazy tracings from their Apple Watch or something, and then I need to figure out what the heck to do with it. So this provides an actual clinical framework that's evidence-based, has very good outcomes, data behind it, et cetera, and will be kind of one of our first formal forays into this in primary care. The DCC, the Diabetes Care Center, has been using RPM for years. In fact, they bill out something like $250,000 in RPM codes on a monthly basis. I know because I get the billing reports. So, this is quite established as a almost standard care, frankly, for type 1 diabetes, definitely for anyone who's using an insulin pump, et cetera. So now we're really kind of bridging towards use in primary care, where, frankly, most people with diabetes are taken care of. RPM is a really great opportunity to use our team to their highest level of scope, to their max, in this collaborative relationship that we work at in primary care, and I think works best to achieve good outcomes and adherence for patients. And it's a chance for us to take care of patients in their natural environment, which is frankly where they spend the vast majority of their life, not in that 15-minute visit with me. So this is what we're going to go through today, the general programmatic components, the workflow, patient identification, the nuts and bolts of enrollment. We're going to talk about data submission and upload. We'll talk a bit about how to use CGM reports, and then we'll talk about coding and billing. This I'm not going to go into in great detail, but if you guys are kind of like a visual learner, you like workflows, this is actually the whole process map of CGM, and it is divided into different swim lanes. Again, this program is very team-based. As you can see, there's roles for everyone, including the patient. This is kind of a good map of all the steps. One thing that we definitely enhanced after we ran the pilot is this section right here around what happens behind the scenes to get the patient their equipment. That definitely was really, really valuable learning from the pilot. It can be a little bit complicated, as we know, and trying to get things covered for some of our payers, such as Medicaid or Medicare. So we put a lot of work into this workflow so that hopefully it decreases barriers to patients actually getting their equipment. So I'm going to spend some time being very detailed on these next two slides because I think this is where it can be a little bit confusing or very confusing, especially if it's new to you. So one of the main feedback that we received from both the nurses and the providers and the pilots was it's very useful to have incredibly clear inclusion and exclusion criteria, especially for new programs that you may be just, picking up a new skill. So let me walk you through this. So patients for this CGM program within primary care are patients with type 2 diabetes. We're excluding patients with type 1 diabetes. If they have type 2 diabetes, they only need one or more of the following criteria. They could be on insulin, which I think is maybe the most typical patient for CGM, but they don't have to be on insulin. They could be someone who is just having difficulty with glucose management, and that is hyper or hypoglycemia. These could be patients that, for years have refused to poke their fingers. This is actually a really great fit for patients that have some barriers to using traditional glucose monitoring. Or they could just be patients who want to tailor their lifestyle. I definitely, Ravenna was one of the pilot sites, and this is actually quite useful for some of my newly diagnosed diabetics who did not want to take medications. So, as a first step, some of them eventually ended up on medicine, and I think the CGM helped kind of illuminate that need for them. But this is kind of a good place to start for, maybe someone with a new diagnosis who, wants some more evidence, before they, start taking metformin or something. We deal with all types of people, all different types of mindsets. People who are excluded, so as I mentioned, people with type 1 diabetes. Additionally, anyone who's getting care from their endocrinologist, even if it's for run-of-the-mill type 2 diabetes, we're not going to include them. If they are interested in CGM, they should talk to their endocrinologist. This is mostly because of billing concerns and, worrying about double dipping and, patients getting bills that aren't covered, et cetera, if they have, two providers providing the same service. We're also not doing this for pediatrics or gestational diabetes. There are some good places to kind of mine for patients that might be a good fit that might benefit from this. Obviously, I'm sure all of you guys have some highly complex patients that are already enrolled in care management who are getting a lot of support from your RN. So if you have some patients from that pot, they might be good fits. Again, you could also work with your panel navigator. I know there's always a enhanced focus on diabetes population health. So, that's a good place to start, running your diabetes list and looking for people not at goal, and then considering if this would be a good fit for them. Hey, Nika, just a FYI, if there's things in the chat, just please let me know because under the speaker view, it's really difficult for me to see the chat blowing up, okay?
Okay.
All right, so we just talked about inclusion criteria. So purely medical, what features of a patient make them a good fit? Now you have to overlay insurance coverage. And I think the mindset that I'm trying to get providers to think about this, it's just like prescribing a medication that, maybe some insurances only cover for certain diagnoses, or you have had to try something else before. That's exactly what you should think about CGM, like in that same pot. And I think it's just easier for those of us who are, used to practicing a certain way. We have these certain boxes in our mind and we feel like comfortable and having the conversation with patients, et cetera. So this is where I would park this in the same pot as, getting coverage for Lyrica or something. So just because you meet our inclusion criteria doesn't necessarily mean your insurance is going to cover it. Just because your insurance doesn't cover CGM doesn't mean that you aren't actually a good candidate based on your medical needs. So here's this grid, and this changes all the time. In fact, coverage for CGM and RPM has been improving over time. It's doing a very similar thing that we saw telemedicine do. So, I think that this will change. I think this is becoming more and more the standard of care and widely accepted. And I think Rick sent out a really good set of articles that was put together by Earl Hirsch, who's a diabetologist here at UW, looking at the evidence. And kind of uniformly for patients with insulin, this CGM has really shown improvement in A1Cs. In patients who are not in insulin, there's a little bit of mixed bag of evidence. I would say that it's coming, but it is FDA approved for that. And, if you look at the ADA website, and they have some information about self-monitoring. And basically, they have a very kind of I don't want to say relaxed stance, a very to be interpreted stance, basically saying if the patient is willing to engage in self-monitoring, this will help them, make good lifestyle decisions, then they're for it, basically. But there's more clearer evidence base for use in insulin. I think that's where, Medicaid and Medicare, are really kind of focusing coverage in on patients who are on insulin. But, the body of evidence showing this to support just in general global lifestyle selection, engagement in diabetic care, et cetera, is growing. So here's a grid. So for commercial insurance, basically anyone with any sort of diagnosis of diabetes, even type 2 diabetes, uncomplicated, not on medications, no hyperglycemia, et cetera, would be able to get this covered under their, medication benefit. For Medicare and Medicaid, this is where you start getting a little bit more restricted. So Medicare will cover it for patients who have diabetes, who use TID or greater insulin, and quote unquote need frequent insulin adjustments. There's no like objective criteria you have to prove for that. It's just more about chart note documentation, which we'll talk about in a couple slides. For Medicaid, I would say this is the most restrictive, and our RNs and RDs actually had the most problems for Medicaid patients while we were trying to figure out a rubric. I think we actually have a much better system now where the prior authorization team will help support it. So I think that this is going to be less of a barrier now, but this was a hard nut to crack, and we had to, kind of figure out exactly what documentation was needed, exactly, what Medicaid wanted to hear, et cetera. So for Medicaid, you need the diagnosis of diabetes, TID or greater insulin, needing the frequent insulin adjustments, and then you also need to be ideally self-monitoring at least QID. Doesn't necessarily mean the patient has had to do that. It means that you as a provider had recommended that they do that, and maybe, because they're not someone who wanted to poke their finger that much, they weren't, being compliant with your recommendation. In which case, that's a really great reason to put them on CGM. So we'll talk about some of the specifics of ordering for these different payers in a couple slides, but let me highlight this self-pay option. So RPM codes, meaning the codes that you and I bill, or the codes that your RN or RD are going to bill for their time associated with this program, are universally well covered by all payers. It doesn't matter for what reason. And we know this because we ran a hypertension pilot where really literally everyone only had, hypertension, and we got 0 denials from insurance for the RPM codes. The problem with CGM and these insurance coverage criteria is the cost of the equipment, which a pack of 2 sensors, which is 1 month, costs about $70 if you pay 100% cash. There's often coupons that you can get from the Libre website or through GoodRx, et cetera. The pharmacist can actually even run it through the GoodRx benefit and get the patient a better cash price. So there might actually be some patients who want to do this enough, that are motivated enough to do this, even if their insurance won't pay for the sensors, they're willing to pay cash for it. So, don't let this be a barrier. We're also helping, I know Allison Everett is super pro CGM for all use cases, all groups of our populations, and wants to help patients overcome barriers to be able to use this technology. So anyway, so there are some tips and tricks in getting patients access to it. But the program itself has actually been very well covered by all payers. Okay, so let me just take a moment to talk about consent. I would mirror this, and we tried to mirror our workflows very similar to workflows that we already use. So for instance, when you refer someone to care management, you follow a similar workflow. So first of all, consent needs to be documented in the chart. I think for most of you, this will be done face-to-face or via telemedicine in an actual visit. You're doing a diabetes follow-up. You're saying, hey, what do you think about CGM? Would this be a good fit for you? And the patient says yes. And so you document the consent using this .rpm consent in the chart. Now, you can also do this via phone call or e-care, or I should fix this. It should be my chart messages. You can do it through there, similar to how we get consent for e-consults or something. Just make sure that it's actually documented in the chart. That you had the conversation. You ask the patient, like, do you want to enroll? The patient responds through my chart, yes, I would like to enroll, and then you can put the consent in. After the patient's consented, you're going to order a referral to RPM, and this actually goes into your nurse's work queue, similar to care management. And this is also just to additionally stamp the chart for compliance that you as the PCP are authorizing this program for the patient and you are referring them there. There's actually an enrollment AVS dot phrase, and this is where better tools to help us get insurance coverage for the sensors comes in, because in this enrollment AVS dot phrase, it has all of the little verbiages, that insurance needs to check the box to get your patient covered. So it's got some language about medical necessity, has some language that I am prescribing this for medical necessity to control the diabetes. And then it also has some language that's specific to Medicare and Medicaid to hit those criteria. Like the patient is using insulin, the patient needs to check their blood sugars, et cetera. So, in streamlining this, basically you're creating a paper trail in Epic so that the prior auth team, when they get that ping from Medicare or Medicaid, they need the prior auth, they can just print your chart note and it's got everything they need in it. And it makes it easy, and there's not this back and forth like, hey, Dr. Wong, you didn't write that this is medically necessary. Can you go back and indent that chart, blah, blah, blah. All of those things that you and I have had to do for other things. So anyways, so hopefully this makes it a little bit easier. And then last but not least, please CC this chart to your RN or RD, whoever is going to be supporting. And in terms of the roles, this is going to be a little bit dependent on your clinic. We are having a training with all the RNs and RDs in the phase 1 clinics next week, and we'll try to clarify that for you guys. But I think depending on the clinic staffing, some clinics are kind of more engaged with their RN, and some teams are more supported by the RD, and there's kind of a mixed bag. Some clinics may be having both as very engaged in this program. So, that's really going to be up to Tammy and Allison to help figure out for your individual clinic what the mix of RN, RDs helping with this program is. But just make sure you get the chart to whomever that is so they know that this patient is coming to them via referral. They can look at it and see your plan. They can start getting prepared to do the intake for this patient. Okay, so once you have, selected the patient, put in the referral, then the consent, you need to get them their equipment. And this ideally would happen in that visit that you consented them. It'll just make less work for your RN and RD. There is a stopgap in the RN RD workflow for them to check and make sure that the patient has been able to procure their equipment. So there is, a safety net there, but, it'd be good if you could just order this in that visit with the patient. And the order is a little bit confusing. So I think the biggest thing I want to say is if the patient has straight up Medicare, they don't have a Med Advantage plan, you have to order this like medical equipment. So you have to order it using DME. So in the smart text for the provider enrollment visit, there's actually a link to this DME form that CMS requires. and you would print the PDF form and fill it out and give it to the patient, and the patient would have to turn it into a medical supply company. So very similar to like if you're trying to get a patient a walker or cane or something. Pressure hose, for goodness sake. For commercial insurance or Medicaid, it's actually ordered like a medication, so it's much more simple. And the next slide, I have some screenshots of what that looks like in Epic. And ideally, you would send it to a big box pharmacy, mostly because the prior auth workflow, if they need it, and then also for better pricing, frankly, if you have a patient that decides they're going to self-pay. As I mentioned, the sensors last 14 days each, so 2 would be a month supply. If you have a patient who wants to do this long term, you could send them in a 90-day supply and send them in 6. This is always the Libre 2. There's an older version called the Libre 14, but we're not using that anymore because that one's not compatible with a smartphone. And on that, for most people who have a smartphone, they're just going to download a free app, the Libre 2 app on it. There you go. You don't have to order them a reader. If you have a patient who doesn't have a smartphone, they have an old-fashioned flip phone, or they don't have a cell phone at all, and they're still a candidate for this program, you would have to also order them a reader. And the same thing, it would go as a medication, just like you're ordering like a glucometer for commercial insurance and Medicaid. It would be part of the DME form if you're doing for Medicare. There are some little weird things, and there are always little weird things that we find out when we do things in real life, that the nurses found out about certain smartphones. I think for the sake of providers, your nurse will be happy if you just order them the stuff and identify whether or not they have a smartphone, and they're okay kind of catching the strange smartphones that are incompatible. So I think that for your sake, I would just say, do you have a smartphone? You do. Okay, cool. You don't need a reader. And if they don't have a smartphone, then you'll have to give them the prescription for the reader.
Dr. Wong?
Yeah.
In the chat, there's a comment from Tammy Wilson to everybody to say that it would be great if the chart was CC to RN and RD if both roles are in a clinic. Yeah. And also, Dr. Kincaid has a question. Are all the consent documents included in a diabetes smart sets or the RN visit smart set?
Yeah, so yes, so highlight and underline in bold CCing the charts. And I think that's a great idea, Tammy. Like, we should just send it to both, and then we don't have to worry about it. Rick, in terms of smart sets, I think that would be an awesome enhancement. It actually takes a lot of work to get a smart set built. And smart sets are pretty locked down in that they have to be system wide. So yes, would I love to have a smart set? Absolutely. I think we need to grow this program a little bit more, get it rolled out for UWPC, and then we could have enough, I don't want to say body of evidence, but have enough to get IT to support that. Also, frankly, we're in an IT freeze right now. I think you guys may have heard that because of COVID surge. So IT has said they're not doing anything that's not related to COVID right now. So, one of the other things I was going to mention is, we built a lot of these, smart texts for the pilot. And so they were tested by real live people. And then we edited them based on feedback from people who were using them. And so I think we have a better product. That doesn't mean they're going to be perfect, though. So if there are edits that you feel like would make the standard smart text like more clear, et cetera, or you find yourself like adding something every single time, please let us know, and we can track those and kind of assess the feedback and potentially edit some of the IT tools as we get out of the IT freeze. So we'll kind of bookmark those for when we have IT resources again. Anyway, so here's a screenshot of the order. You can see the bottom right is the Freestyle Libre 2 sensors, and the top left is the Freestyle Libre reader. This is just what happens behind, behind the veil. your hardworking care team. So when you send the referral to RPM, it goes to the care management work queue. The RN and RD will evaluate the referral and make sure that everything they need is in there, including reaching out to the patient to say, hey, you know, Dr. Wang ordered you Freestyle Libre sensors. Were you able to pick that up? Okay, great, you did. Cool, let's schedule your intake. If they call them and they're like, I don't know, like, I haven't heard back from the pharmacy or my insurance, you know, X, Y, or Z, that's where, you know, they'll check in, you know, with the prior auth team, et cetera. If for some reason it slipped your mind and you didn't even order it, they'll in their checking will catch that and send you a message and say, hey, Crystal, like, thanks for the referral to RPM. Can you remember to sign a prescription for the sensors? Here it is, I pended it for you. And then I will remember, I will sign it right then and there. And then, you know, if all the boxes are ticked, they're going to go ahead and schedule the intake appointment, which in which they will do a couple things. One is, you know, teach the patient how to use the device, as well as do some lifestyle history taking, and as well as some coaching. So this is just some details about, you know, what's going to go on, you know, if they need the prior auth. I'm not going to go through this, but this is all flushed out with the prior authorization team. That was not support that we had during the pilot. So I know all the RNs and RDs are happy that we have that added in real life now. This is the subject matter of the intro meeting with the RN. So they'll review the program, help the patient set up the device, help them put on their sensor, make sure they feel confident in using it, and then go through some medical history and lifestyle and habits, maybe set some goals to discuss the individualized care plan. And then just please, again, make sure that the diabetes care plan that you are prescribing for the patient is related to your RN and RD, so they can be very clear with the patient on the expectations. You know, you're going to wear this for this long. I'm going to sync, you know, the data this often. You know, you're going to continue X, Y, or Z medicines for now. You know, those types of things your RN and RD need to know the specifics. And just this is just like a caveat. The initial visit right now, the code is only covered in person, and that's because it's supposed to be for device setup. You know, if you had a really tech savvy person, you know, who for whatever reason was putting their foot down for coming in for this visit, you could talk to your RN RD about just not doing this meeting and not filling out the code. But you know, I think for the sake of a new program, it's good to kind of stick to, you know, the protocol, especially as we're all gaining experience. But, you know, it's always a collaborative process. And I know we always try to be very patient-centered, and, you know, people have a lot of fears these days, understandably. You know, this is why we're doing these programs, so that, you know, we could bring care into the home. But anyway, so have a conversation. We're going to talk a little bit more about the actual reports later, but this is where expectation setting up front with the patient and really good training is very important, because the patient really needs to wear their monitor continuously and remember to upload their data. Otherwise, you're not going to get enough data in the AGP report to do a good assessment and feel like, you know, you have enough data to change their medications, especially. So this is going to be, you know, taught by the RN and the RD. This is the portal the patient uses. It's called LibreView. It's very easy. We're actually putting together a document that has all of the account names for all of the PC clinics, because the patient needs to input that so that they can sync their data with your clinic's account. We actually have a new tool in Epic that we didn't have for the pilots, so that you can actually trend the GMI, the time in range, and hypoglycemic events. I'll show you that in the next slide. And so this is nice because then you don't necessarily have to either look back at chart notes or look at AGP reports that are scanned into the chart. And you can look at this over time. So it's in the flow sheets section of the chart. Once there's data available, the RN or RD will message the PCP. They actually have a standard dot phrase they will use that actually summarize the key metrics in that phrase. So you can just read it in the note, you know, just for kind of a quick, when you're quickly going through your in-basket. And then it'll also have the link to the PDF scan of the AGP report. And then if you also access the flow sheet, you can see the trend of the data. So this is what the diabetes flow sheet looks like. And in this little search box, you can see right here, you can just write diabetes. And then it's this one, it's called diabetes MA note. You'll see it pop up. And you'll see it has these little yellow highlighted things. So it'll have the GMI. Hopefully yours is not 28%. That would be horrible. A time in range and a time below range. Anyways, this is for, and then, you know, if there's multiple values, you'll see them kind of laid out depending on the time frame that, you know, you're selecting for the flow sheet. But anyway, so this is a helpful tool so you don't have to go chart mining. Let me pause there. Are there any questions before I actually jump into more of the clinical nuts and bolts about AGP reports? All right, feel free to put them in the chart if there's questions. Okay, so this is what a AGP report looks like. This is actually what your RN or RD will get from LibreView. And just to kind of give you a layout, so this would be, sorry, I keep using my other screen. This would be over here in the upper left-hand corner, kind of your key metrics summarized. This over here on the right shows you the amount of time they spend in different ranges. So whether that is your target range of blood sugar, well, the interstitial fluid glucose of 70 to 180, or in your above 180 range or hypos. And then down here on the bottom, you get a ambulatory glucose profile. So kind of like an average glucose by time, and then you actually have the individual days down here if you want to, if there's, you know, a very aberrant day or something. But this is it kind of averaged and smoothed out, so you can kind of see, you know, what your patient's glucose is doing per time. So it's basically just like a much better visualization of random chem sticks, you know, that your patient might be doing, like, you know, preprandially, postprandially, et cetera. So anyways, we'll go through each section in a little bit more detail. So, okay. So first let's look at the time in ranges, which I think is a really helpful visual. So time in range in the target goal of 70 to 180, for good diabetes control, you want to target greater than 70%, and a percent of 70% corresponds to an A1C of 7%. So that's what it's looked like when the validation trials for this device. 10 below range, your goal is less than 4%. And then I think time above range, the endocrinologists don't typically use this as like a key metric, but you know, I think it's good to kind of pay attention to that. I think the time in range is a little bit of a better, you know, kind of global metric, but the time above range, I think it's better to use that in the interpretation of the actual glucose profile, meaning the curves, to kind of look at when those spikes are, and then maybe time your intervention based on that.
Dr. Wong, Dr. Kincaid has another question in the chat.
Sure.
Could you briefly talk about the cost of the Libre 2 for self-pay? I might have missed that.
Yeah. So self-pay completely cash for 2 sensors at $70. And I know this because I've had patients go and buy them themselves. Usually you can get a coupon. I think actually one of my patients was able to get a coupon from the LibreView website for to bring the cost down to $50 out of pocket. So that's, you know, $25 a sensor. So, you know, you might have patients who are just very interested, you know, maybe, you know, their insurance wouldn't cover it otherwise, and they just want to do it for 6 weeks, and they're willing to, you know, pay for, you know, 4 sensors, or sorry, 3 sensors, you know, just to get that information. So again, I think that's where, you know, the conversation, and I think it's more about programmatic fit, and then we can figure out, you know, the cost of sensors. Sometimes you can actually even get free coupons for free sensors. It's just kind of depending on what can find on the internet. And again, the RPM codes are very well reimbursed by all payers. Yeah, anyways, if you want to talk to me about that offline, I'll do it when I'm not getting reported, because there's some things we learned during the pilots that might make you really want to do this now while payers are maybe not being so aggressively hunting this down, nor is UWP, frankly, going after a lot of outstanding accounts on this. But anyways, so this over here, so again, if we go back to this, this is, now we're going to be talking about this upper left-hand corner right there. So you want at least 14 days of data with at least 70% adherence, meaning they're wearing the sensor, they're scanning their sensor, they have data for at least 70% of the time for this report to really be clinically valid. So again, that's where, really good training of the patient early on is important, because, otherwise you're gonna get a report and you're not gonna be able to use the data very well. They have to sync the device at least every 8 hours. That's just how much data the sensor stores. If they go beyond that, they're gonna lose their data. So, and it's very easy to sync. You literally just take your phone and hold it up to your arm. So, hopefully that's not gonna be a huge barrier for patients. So in this part of the report, you're going to find, how long they wore it. So this is 28 days. How often, what percentage of the time their CGM is active in sync. So this patient was really good 98% of the time. It's going to have a little bit about the glucose ranges, although again, that last part of the report I think is more helpful for looking at that. But here's going to be your key metrics down here, including your GMI, which is essentially the calculated A1C based on the sensor data. And then you also see down here this variability. Your goal is for less than 33%. Minimizing lability for the patient will decrease the risk of hypoglycemia, especially for patients who are on insulin. So I think here's like a good rubric for just, thinking through how you're going to interpret these AGP reports. So number one, is this report valid? Is there enough data in this report that I can actually make good decisions based on it? Number two, you can do the interpretation without the patient. That's not actually a requirement to bill out the code for that. So, you could just do it in basket time. I think though, the real benefit you're getting from CGM is the improved conversation with the patients about diabetic control and interventions. And that's where, I think the major benefit is sitting down with the patient and looking at the report together. So I would say that's the best practice. It's not essential for hitting the billing requirements, but I think that it's, you get a lot of good conversations out of it. You're going to look at that curve and identify, when do you eat, when do you exercise, when do you sleep, when are you at work, did you travel? I mean, all those things that kind of go into, what is causing the glucose fluctuations. And this is the similar frame of reference you have mentally, if you're bringing a patient in and they're bringing their old-fashioned chem sticks and you're looking at that, like, okay, when was this 250 from? Oh, you had just eaten ice cream, those types of analyses. And then you're going to look for patterns. So number one, is a patient just in their target range? If they are, awesome. You don't have to change anything. Are there areas of hyper and hypoglycemia, and what trigger those? And then you're going to make an action plan based on your analysis of the curves. There is a interpretation note, the CGM RPM interpretation note, that has basically you acknowledging that you've reviewed all these key metrics. It has kind of like a care plan area. And if you use that note, then, that meets the criteria to bill out the code for interpretation of a report. In a couple slides, there's actually going to be a billing grid that kind of breaks down the different charges and who drops them, when to drop them, et cetera. So I won't get into that now, but that's a good reference. And then after you do your interpretation, please also send this to the RN and RD so they know that you looked at it. They see if there's been any changes that you put into place. Here's also just kind of a summary. We also have another slide here that has all of the dot phrases kind of broken down. But this is just kind of to talk through them. So there's a RN follow-up visit note. So this is for your RN and RD to use, you know, in that in-between care, like maybe they outreach the patient and, you know, wanted to check in on medication adherence or lifestyle change or whatnot, they can use that. They'll also use that for just the administrative time they use to help get the reports from LibreView. All of that time is actually billable. It doesn't have to be face-to-face with the patient. So, you know, if your RD takes 30 minutes, you know, log into LibreView, downloading the report, putting it into Epic, you know, analyzing it, inputting the data, and then sending it to you, they get to bill out that amount of time. And, you know, this is where, you know, hopefully we're pushing medical care in the future, which is actually getting compensation for the hard work that not just the provider does. For report interpretation, there's that interpretation note, as I just mentioned. This will, you know, you'll put this in Epic and CC it to the RN/RD. You're only allowed to bill this once every 30 days. So you kind of have to track it a little bit. You know, one of the enhancements that we'd really like would be a module that actually tracks time and drops codes automatically. You know, we do have some similar modules for care management. It's just, you know, an enhancement that we're not able to, IT is not able to support that yet. And then there is this treatment AVS dot phrase, and either the PCP or the RN/RD can use this. This is basically just a global summary of the care, and it kind of pings you to paste in the plan for the patient, just so the patient can have some good instructions. So that is there. And then, you know, between visit, you know, you'll just be getting messages CC'd to you, similar to, you know, if your BHIP team is talking to you, or if your RN is talking to you about a complex care management patient, whatnot. So it should kind of fit into our kind of thought paradigms of, you know, normal day-to-day things. This is the billing coding grid that I mentioned. You know, this might be one of the good resources to print and just have at your desk while you're getting used to it. And you can see it's got the specific CPT code. It's got a description of why you would use it, whether it's time-based or not, the time unit, and then who is going to use it. So the first one, the 95249, this is really for the RN intake. Sure, providers can use it, but this is mostly going to be the RN/RD doing this visit, and they'll use this dot phrase. And this is only billed out once. This is just to teach the patient how to use the device. There's the 95251. This is the one that the provider is going to be using most frequently. Again, these other codes are billable by the provider, but I think that's mostly going to be the RN/RD using it. So for the providers, the 95251, this is the interpretation of the AGP report, and you can use this every 30 days. And there's the dot phrase there to help you document that. Then there are two time-based codes, the 99457 and 99458. These are going to be used by the RN and RD to help bill for their time spent either doing administration stuff or even direct face-to-face conversations with the patient. They can bill these out, and those can be billed once per calendar month. And just let you know, reimbursement has been really, really good. In our two pilots, which were quite small, I think we had a total of 25 patients total between hypertension and CGM. We've collected over $8,000 in reimbursement, which is pretty awesome for things that typically didn't used to be reimbursed, like your nurse's time. We also have a job aid, and again, Mika will send out these links. It's got screenshots, it's got summaries, it's got those tables. And it's only 8 pages long if you want to print the whole thing. It's not, you know, a 30-page long job aid, but you can also just print out sections that maybe resonate with you. So for instance, the billing coding summary table or the smart text summary, et cetera, you know, the things that are handy for you. Here's some additional resources. Savisa did a really great training for all of the pilot clinicians on using the AGP report, so you can watch that. This is the link to the toolkit with all those job aids. And then there's a really short, it's like 11-minute training video from Abbott that goes through cases. And this is also just kind of a a really great guide for those of us new to using CGM reports. This is a summary of all of the smart texts that we have constructed for this program. So there's the consent, there's the enrollment, there's the RN intake note, the RN follow-up visit notes, the interpretation notes for the providers, and the AVS for the patient. We also have some other like patient-facing things. They're not in this deck, but the managers are aware. So there's like a FAQ about CGM. There's some other patient-facing materials that they have available. So, you know, if you need a stack of those or whatnot, you can talk to your manager. All your managers are getting trained in this program as well. And I don't think I'm going to do a demo because my PJ4 access has not been working, but I will field some questions if you got them.
Crystal, I'm assuming all the slide decks going out to everybody.
Yep, Mika, after this, he'll send you a summary of, and I think you actually might have it already. But anyways, he can
Yeah, I do,
resend
but
it.
I
Plus,
just
yeah.
want to make sure everybody gets it.
Yeah. If you could just disseminate, I don't think Mika has access to the UWNC provider list.
Okay.
Well,
Well, as long as I have
send
it,
it to your.
yeah, have them send it to me, and then yeah, Mika, if you could do that, and then I'll make sure everybody gets the deck.
We'll do that. It will be a little later on today because I would like to include this recording in the email as well.
Okay. Yeah, because we have several people that weren't able to attend, so we'll want to make sure they have the opportunity to do that. Any other questions from the group around specifics, or if you've had experience doing this before, or if there's other things that we need to know before we start using this modality? Well, looks like you answered everything, Crystal. Thank you.
There will be ones that come up, believe me. We're here. You know, I think we're trying to make sure that the RNs and RDs have a really good foundation, because I think that, you know, that's going to be your main source of back and forth. And also just FYI, every clinic got some free sensors to practice with in a kit. So if you want to look at them, your RN should have them.
Okay.
Yeah. But
Haven't
anyway,
seen 'em
so
yet.
yeah, please, please give us, you know, feedback if they come up. Definitely, if there are ways the Epic tools could be better, we want to hear that as well. Although we're out of pilot phase, that doesn't mean that we, you know, don't want to, you know, have new iterations of the program. And again, you know, with my other digital health work, we're really trying to improve our Epic tools, you know, things like smart sets, or even, there's actually even a patient self-service module that Epic has available. So anyways, there are a lot of things on the horizon that will probably be coming, but I'm really excited to get this started in its current phase. So thanks everyone. Have a great Friday and a good weekend. And, you know, please reach out if you have questions.
Good. Thank you very much.
See you
Thank
later.
you.